My name is Professor Clare Scott. I'm a clinician scientist based predominantly at the Walsh and Eliza Hall Institute of Medical Research in Melbourne and as a medical oncologist at Peter Mac, the Royal Melbourne Hospital and the Women's. And I guess the reason I have so many homes is because I've trained both in cancer, medical oncology generally, then as a scientist, and then really focused in on gynecological cancer from the research perspective and also clinical translation, clinical trials, and so forth. So I became involved in ANZGOG more than a decade ago when I was really becoming more informed and learning about designing clinical trials and running clinical trials. And so the clinical trial groups in Australia, one of which is ANZGOG, are really essential in training our medical workforce to do those sorts of things, but to also have a very expert approach that is often tumour stream specific. So in my case, my focus for the last more than a decade has been gynaecological cancer. So ANZGOG is the peak national gynecologic cancer research organisation in Australia and New Zealand, and our vision is advancing research and saving lives. We have shared values that we have come up with together. This is by having strategy workshops, and really this has come from many members being involved. So they're excellence, impact, equity, collaboration, and openness. And I thought it might be helpful if I just give you the four main goals of our latest strategic plan that we're working towards. They're quite comprehensive, and I think they'll give you an idea of the breadth of ANZGOG's passion. So the first is to catalyse innovative, practice-changing, cooperative gynecological cancer research. And that's both preclinical and clinical. To expand the reach, relevance, and impact of our research so that it benefits the community and, most importantly, the greatest number of women possible. We engage, collaborate, and share expertise and insights. And I think you'll find by asking anyone that ANZGOG is known as a very collaborative group. And finally, to sustain a vibrant and efficient research organisation. And sustainability, we all know how important that is. Things just don't survive today without, very much an eye on what is current, what's important, and how do we engage to make sure that we have support to do that. What people really need to understand is that ovarian cancer is not one disease. It's a whole host of rare, low survival cancers, many of them extremely complex, and some of them quite difficult to diagnose. This means that it's one of the most challenging cancers to diagnose and treat. Most people would think of high-grade serous ovarian cancer as being the cancer type that's most commonly seen, certainly in the GP office and in medical oncology clinics, in fact, accounting for the most deaths. But there are equally other sorts of rare ovarian cancer which require just as complex treatment, but we haven't necessarily defined, based on evidence, what those treatment pathways should look like. As a whole, every one of these ovarian cancers is rare in its incidence, so that means below 6 per 100,000 women diagnosed per year, and the majority are low survival cancers. And this makes ovarian cancer one of the most challenging cancers to diagnose and treat, not only because it's symptomatically easy to mix it up with just general symptoms that women have. We'll talk more about that in a moment, I'm sure. But just to put some figures on this, in 2025, more than 1,800 Australian women will be diagnosed with ovarian cancer, and that's 5 women per day. And tragically, this figure hasn't changed while I've been doing this. Close to 1,100 women will lose their lives to the disease each year, and that's 3 women every day. The latest data shows the 5-year survival rate is just under 50% at 49%, and that's significantly lower than the 5-year survival rate for many cancers. And really tragically, 2/3, 67% of ovarian cancers are diagnosed at an advanced stage. And there the survival drops. The 5-year survival is only 29%. And when we think that that's the majority of women being diagnosed with ovarian cancer, we very much keep that 30% in our mind. That's what it looks like to me as a clinician looking after women with ovarian cancer. And then a little bit about the prevalence. So currently there are 5,300 or so Australian women living with ovarian cancer, and for most of those women, there will be ongoing concern, stress, and medical activity related to their disease. So if we look over the next 10 years, approximately 24,000 women will be diagnosed with ovarian cancer. And due to the poor survival outlook that I've already touched on, that means more than 14,000 of those women are expected to lose their lives. The average age at diagnosis is 66, but there is no discrimination. And ovarian cancer can occur at any age. Even very young children in their teens and women in their 20s, 30s, and 40s can be diagnosed with ovarian cancer and then have to undergo usually very impactful treatment. One of the really difficult things about ovarian cancer for both women and their doctors is the fact that they often grow silently because there's nothing around the fallopian tubes from where these cancers begin to really cause any alarm. So they can grow silently in their early, most curable stages and no one has any idea. But by the time they are symptomatic or detected due to symptoms, they're frequently at an advanced and incurable stage. And that's why such a high figure of 67% of patients are diagnosed with advanced disease. The symptoms are often vague and easily mistaken for common, less serious conditions, both by women and by their doctors. And this is because these are symptoms that particularly menopausal women, even perimenopausal to post, so that can go from 45 through 55 all the way out to 70. These symptoms are commonly present, and they are persistent abdominal bloating, abdominal, pelvic or back pain, feeling full, early satiety, having difficulty eating, but really that early satiety is very important. And associated with that, urinary frequency or urgency. Unexplained fatigue, change in bowel habits, unexplained weight loss are also, very common symptoms. But those ones above of bloating, early satiety, and frequent micturition, I think really are a triumvirate that if you hear those, you just have to keep investigating until you're certain that there isn't a deeper cause for them. So unlike many other cancer types, there is no screening test available for ovarian cancer at present. The screening tests that we have, so the CA-125 blood test and the pelvic ultrasound, have been studied in really large international trials and have not been found to pick up cancers at an earlier stage where they're curable. And that means we don't refer to those as screening tests. And it's really important also that women don't mistake cervical cancer screening for ovarian cancer screening. So we do a lot of explaining about those different tests. What we are doing in the research setting is trying to work out smarter ways of picking up ovarian cancer, either in something akin to a cervical swab, but looking for molecular determinants, or of course, a blood test that would actually be more accurate. Another reason why this is so important is, as I said earlier, we have not progressed in improving survival rates. Survival rates in 1975 were really not that much different to today. And we feel very strongly that that's because we can't diagnose women early enough. Also, if we pause and think for a moment about these cancers being rare, every subtype of ovarian cancer is rare, and that brings challenges. They're not all going to be picked up in the same way. So one test will never actually fit all. And that's something we have to think about a lot when we're, in the lab trying to design approaches. So a rare cancer is any that is less frequent than 6 per 100,000 women diagnosed per year. And so for a range of these ovarian cancer types, the incidence rate will be less than 0.1 per 100,000 women. And when we're caring for all women with ovarian cancer, we have to have uppermost in our minds that variety of diagnosis and the variety of ways in which the molecular genetics might differ, presentation might be somewhat similar, but actually detecting that through a molecular method and then understanding that cancer fully and applying personalized treatment is also extremely challenging. Because we know that so many women are diagnosed with advanced ovarian cancer and the survival is very poor, it's actually really challenging to perform high quality research on all aspects of the patient journey, and literally to have women around who are there as strong advocates and strong advisors to other women, because the death rate is just so high. And in fact, I just want to pause for a moment and talk about the psychological impact of an ovarian cancer diagnosis and the psychosocial effects of that. So physical changes caused by the treatment include scarring, loss of reproductive organs, loss of sexual function, and this leads a woman to have significant body image concerns, reduced self-esteem, and mental health challenges. And so for many women, that fear of recurrence remains an ongoing burden, even during the years when they might be cancer-free, or even if they potentially are cured. It's like they just can't believe that. And in fact, a recent study by Ovarian Cancer Australia confirmed that 55% of women diagnosed with ovarian cancer experience anxiety, 36% experience depression, 66% experience ongoing fatigue, 51% insomnia, and 48% a fear of recurrence. And that would be in women who are fortunate enough to be alive long enough to be asked those questions. So if we put that together, we have a very big challenge with a lethal rare cancer, which is not enough women able to assist in telling their stories and raising awareness. Now, for ovarian cancer, we're better off than for a lot of other gynecological cancers, but compared with the common cancers, breast cancer, bowel cancer, lung cancer, where we still see incredible challenges, and that goes the same for prostate cancer, which is a common cancer, we know how many stories we hear about difficulties with diagnosis and treatment of those cancers. But with ovarian cancer and other gynecological cancer types, the number of people able to advocate in all areas, both in the medical research setting, in the government setting, community, industry, really make awareness a very difficult feature. So the number of subtypes that we have also makes it challenging to raise research funding, because different people will be focusing on different rare subtypes. But for each of those individual rare ovarian cancer subtypes, it's difficult to have a really strong track record. And track record is everything when it comes for funding for research. We look these days genomically at a lot of issues related to cancer. So molecular profiling is super important and is very, very helpful in terms of both understanding the different type of ovarian cancer and having some regard for treatment. And also it's a very solid thing to be able to take into that funding or grant funding setting. So molecular profiling is best done at initial diagnosis, particularly with women who have a very short survival period. But so far, we're not able to do molecular profiling other than for HRD, homologous recombination deficiency, which is a form of DNA repair defect, and for BRCA1 and BRCA2 mutations in the tumour, just for high-grade epithelial ovarian cancer. And we only get those specific answers about BRCA1, BRCA2, and HRD, and hopefully some more BRCA genes now. But there is so much more that we need to know. And we need to have that information early enough with an early lethality cancer to make a difference, not just with designing second line of treatment for women, but also with incorporating the right women into the right research, because otherwise we just continue to generate data which may not be as informative as otherwise. So molecular profiling is super important. We don't have enough access to that at the moment, but ANZGOG's research is already changing the way we diagnose and treat ovarian cancer and really shining a spotlight on the importance of molecular profiling. We need to accelerate progress to ensure no woman is left behind, and this is a theme that we will continue to promulgate because we really think it is the first base to reach, not the second or third or a home run, but we can't do anything without getting to first base. So we partner particularly with OMICO and in many ways with other programs like the Zero Childhood Cancer Program, who have already shown that these approaches can save lives. And because, as I've mentioned, our cancer type is rare, we want to work with our colleagues from these really important partnering organisations to show that their data is relevant for us as well. The barriers to the adoption of comprehensive molecular profiling in routine clinical practice, as opposed to in research, include the fact that we don't have established guidelines for implementing molecular profiling in routine practice, although we do have recent genomic guidance, which is at the government national level recently published, and that's a really great step in the right direction. So people in government and in industry are certainly aware of the importance of this, and we really hope to see more improvements and advances, particularly over the next 12 months. So the second thing is clinician knowledge and education. And if we think about, for example, medical oncologists or cancer specialists, let alone GPs, think about the number of different cancer settings that they have to have oversight on, and they have to become familiar with the language that we use. And that is something that is being addressed, but it just keeps, it's like running a race that you can't actually win because the goalposts keep getting moved and the finishing line keeps being moved. So we need approaches to assist clinicians with interpreting complex genomic data. And so supporting any of those initiatives is really important. Then there's reimbursement. So I spoke before about the fact that women now can receive HRD and BRCA testing reimbursed after their first diagnosis by the government. Disappointingly, women who were diagnosed some years ago and didn't receive that at that time are not entitled to receive it when their cancer recurs. So we have to get those women into research studies, but there's no reason why those women should not be receiving molecular testing then. And what we really need, as I said before, is more than just HRD and BRCA testing, but comprehensive molecular testing. And women have to pay for that otherwise. So there again, we immediately see a socioeconomic gap, with women being able to pay $3,000 for an HRD test that they're not entitled for because it's not first diagnosis, or being able to pay for other molecular tests to really get genomic information early. The other thing I'd like to talk about just now is the limitation in resources and infrastructure. Now, a lot of this is being built. Government and also industry have contributed hugely over the last 5 years, and we're in a better position now than we've ever been before. But for people with a rare cancer, it's still not adequate, and particularly not in regional and remote areas. So prior to COVID, and then enhanced actually by COVID, many of us have been designing ways and streamlining methods for reaching people who live outside the big cities, who can't find it as easy to turn up to the big cancer centres to ensure best care. They often have questions, and we want to reinforce the fact that they have doctors who are able to receive expertise, expert advice, if that woman's cancer type is not one which her medical oncologist normally treats. It's really important that women feel confident with their home-based medical oncologist. We don't want women to have to travel huge distances, huge Australian differences to get the care that they need. So there are a range of other entities looking to close these gaps, which I'll talk about in a few minutes. So the infrastructure and interconnectivity and the partnership of all of these different entities that I've mentioned is recognised both by us in the space, so ANZGOG, OMICO, Zero, which I mentioned, the various large cancer centres, and Cancer Australia, the clinical trials groups. We're all aware of the not only need to come together, but the profound positive effect of coming together and being collaborative. The most important message for the Australian government and other people within that community is that unquestionably investment in research directly translates into improved cancer survival. We have shown that across many aspects of cancer care, and overall cancer survival rates increasing by 43% has occurred because of significant and sustained funding for high impact research. But these advancements have not been shared equitably across all cancer types. Most women diagnosed with an ovarian cancer particularly are diagnosed with a rare cancer, and the survival rates and treatment options for rare remains poor. These rare subtypes therefore remain underfunded in terms of access to targeted therapy, under-researched, with little chance of these new targeted therapies becoming an option for those women, and that is maintaining a lid on the survival rates, increasing the number of women who continue to have poor survival rates and limited treatment options, while other types of cancers have more what I would call 20th century treatments. And whilst there has been an increase in investment in ovarian cancer in the past decade, it's been modest in scale given the historic underinvestment and degree of need over time. So our critical gaps remain in understanding the molecular profile of these rare and less common cancers, and this limits treatment options and contributes to preventable deaths. So I had already mentioned how the limitations in access for people with ovarian cancer to precision medicine and molecular profiling. At the point of recurrence, additional molecular profiling is required to make sure whether the cancer has changed in the interim and to determine which therapy will be best going forward. The way we think about that at ANZGOG is more small, smart, nimble clinical trials. This is really important because we need access to a wide range of drugs, and we need them to be available without too many restrictions, including for women with rare cancer diagnoses. So Omico's platform and ANZGOG's OASIS signal-seeking studies are very important initiatives. So we really want a transformational, streamlined approach to personalised medicine. That is the single most important thing. Availability of these trials that will be more accessible to women, ensuring we have more of the modern targeted drugs in an open set of trials that aren't too shut down, so we can get people with rare cancers onto them. We're really keen to have our community involvement continue to increase. ANZGOG is very passionate about involving our community volunteers who provide feedback to us on a huge range of topics. I've already mentioned Omico. The Australian Rare Cancer Portal is another way of reaching people in the regions and remote areas and ensuring that their doctors receive expert advice. And not one organisation will make a difference. We know we need to all come together, and we are doing that. But from the perspective of women, particularly with ovarian cancer and other gynaecological cancers, our programs remain critically underfunded compared to many other cancer programs. And until we change that, these numbers won't change. We've been so thrilled to see the prioritisation of women's health issues, greater awareness, acknowledgement and support. And we've seen that in recent federal announcements, both this year and last year. And we really hope that that will go partway to redress the gender bias in research and availability of different aspects of cancer care, which is widely acknowledged as existing by Cancer Australia, for example. So really continued investment in research and streamlining of programs would be the critical ask from ANZGOG. We have this fundamental interest in preclinical research in order to better design our trials, and funding of clinical trials ensures that we learn more, we document what we learn, and we apply that to the next trial. That's the archetype of small, smart, nimble trials. It's a pipeline of trials, as in fact we can describe for every common cancer type that has improved their outcomes. So it would be crazy to think that we can improve outcomes if we don't do something differently. And taking the same approach that has worked for common cancers, but in a more complex and yet more flexible way, is required to improve outcomes for women with ovarian cancer.